So the indications for iPDT, for photodynamic therapy, are patients with malignant gliomas that have recurrence. And patients that have recurrence with malignant gliomas are patients that don't have so many other options. Usually we go for repeat surgery if we can do that, and followed by radiotherapy and maybe targeted therapies, but none of this really has a large database to support the therapy, so there's no real standard in the current situation. If the recurrences are deep-seated and small, then those are particularly well suited for interstitial photodynamic therapy, because with the method we have a minimally invasive method for reaching the tumors, and we know that we are killing tumor cells by doing this. Our experience states that it's safe, however, and the major risks are actually those related to the stereotaxy itself rather than to the treatment. And the other important thing is that there are no interactions between this and maybe radiotherapy or chemotherapy. So it's completely independent. There's no additive toxicity or anything. The technique we have at the moment requires that the lesions not be too large. If they get too large, we don't have the number of fibers available at the moment to cover the entire tumor. So anything up to a size of about 2.5 centimeters is feasible. The photodynamic therapy is based on the fact that if you give ALA, 5-aminolevulinic acid, and it is converted into protoporphyrin 9. Apart from being highly fluorescent, which we use for surgery, it's also a very, very good photosensitizer. So what happens is that if we give light of sufficient energy and the correct wavelength, which would be 633 nanometer light, and get it to the tumor cell, the protoporphyrin, which is the metabolite of 5-ALA in the tumor cell, interacts with the light to go from a ground state into an activated state. From there it interacts with molecular oxygen, causing or changing the molecular oxygen to something called singlet oxygen, and that is a very highly toxic oxygen species which attacks physiological membranes, mitochondria, and also the normal cell membranes, and effectively kills the cells. Okay. That's one method of action. The other method of action we suspect is that by this very special kind of cell death, which is somewhere between necrosis and apoptosis, we are probably inducing an immunological response. And because some of the long-lasting improvements in patients we cannot otherwise explain. Okay, but so we don't know this for sure, and we still require randomized studies. So that's the mode of action. I think the hard part actually is getting the light into the tumor, and the 633 nanometer light is red light, does not penetrate far. We know from experience and laboratory work that we can achieve about a penetration depth of 5 millimeters with the energies that we have in our lasers, and with the time which seems suitable for this. The procedure actually is much like normal stereotaxy. So in our department, we put on the frame, the patient goes through the CT scan. This is fused using image-guided software to the MRI, and then we calculate our coordinates to place the fibers, which are tipped with diffusers, into the tumor. Okay, so these fibers are connected to laser by Modulight. We have up to 8 channels, and these fibers are tipped with a diffuser of 2 centimeter length or 3 centimeters. We can go up to 4 centimeters or down to 1 centimeter. Usually it's about 2 centimeters. And these diffusers have to be strategically placed into the tumor so that we can be sure that the entire tumor is really illuminated, because that is the really, really tough part, getting the entire tumor to be evenly illuminated. It's important to know that you cannot overdose this. The lasers don't cause heat, or at least the energies that we are giving don't cause the tissue to heat up, so it's really a photosensitizer and light interaction. It's not heating. This is not laser-induced thermotherapy. And so these diffusers have to be brought into the tumor, and we know that the way we're doing it now with the energies we are applying and the timelines we are applying, we have a penetration depth from the diffuser of about 4 to 5 millimeters. Again, the main issue is getting the light into the tumor, and so the planning is really important. Then we do the procedure, and I will get back to the procedure in a minute. After that, we usually do an MRI at the first postoperative day, and we can see the effects of the phototherapy. We can see that. We use the Lexa system, and this comes with a particular holder which holds sleeves, metal sleeves, which are like long, hollow, small rods for first placing our trajectories for the fibers. And this is important, that you first have to puncture the brain and create your trajectory with this very narrow sleeve, because the laser fibers are flexible, they're pliable, and you kind of push them into the brain, they will deviate from the planned trajectory. Okay, so that's why we have these sleeves. Okay, then it's just like zero taxi. We create our put on the frame, we create our burr holes, we put in the sleeves, and then we place the diffusers into the tumor. And to be sure that we have them at the planned depth, we have to use normal radiography. So we have a plain X-ray in the operating room, and then we put in, just like normal stereotaxy, we take a sample of the tumor for frozen section to make sure that we are faced with the tumor, because sometimes there are reactive changes in brain tissue after therapy which mimic a tumor. Neurosurgeons know this, it's called pseudoprogression. And then we would start with the treatment. So we would strategically place up to 4 fibers into the tumor tissue. What we usually do is we calibrate all fibers first, and then so they're lying on the table, they're all calibrated, and then we place them into the cavity one by one. And importantly, what we do with these patients is that they all have oxygen at 100%. We start that pretty much very soon in the anesthesia, because the interaction between the protoporphyrin 9 and the membranes goes via singlet oxygen, and the higher the oxygen levels in the tissue, the more singlet oxygen you have. Maximum sensitivity of the skin of the tumor is at around 8 hours. So you ingest this drug, and then you start having significant porphyrin 9 after about 4 hours, and 8 hours is the maximum. So the increase is rather quick, but the decrease, the attenuation, occurs much more slowly and goes until the next day. I would suggest to anybody that wants to do this to go to a center that does this, to see once in action, to see how the procedure was organized, how to do this. Usually those people doing this will also be doing flow-sense guided resections, so they already know about the drug and what precautions to take with the drug.